All right, so I'm going to speak on basic approach to fibrosing ILDs. I'm aware that there's a fetal workshop or lecture down below, and we can never compete with babies, right? I mean, that's just impossible. Either they cry and take away your attention, or they just take away your attention. So I'll spend a little time trying to talk about how it is that I and the community approaches fibrosing ILDs. I have a bit of an algorithm that we'll run through, and I don't know if you have time for questions, perhaps not. So whenever we have interstitial lesions, and these are the three signs here of fibrosing ILDs and the rest here, which I'll talk about in my next lecture, which is following this. The first thing we need to do is figure out whether it is a fibrosing ILD or a non-fibrosing ILD. And fibrosing ILDs are characterized by these three signs. They start with honeycombing, which is a very specific sign, but not seen in all fibrosing ILDs. Cysts with shared walls that start in the subpleural interstitium and extend up to the hilum, always associated with traction bronchiectasis and reticular opacities. Then we have traction bronchiectasis, which is irreversible dilatation of the bronchioles. You may not have honeycombing, but you will always have reticular opacities. And I'll talk about reticular opacities again in a little while, but this is what they look like, where you have linear net-like lacy opacities extending up to the subpleural interstitium, sometimes with a little bit of traction bronchiectasis, but sometimes just on their own. Now, when we see any of these, reticular opacities, traction bronchiectasis, honeycombing, we know it's a fibrosing ILD. The next step is to ask ourselves, is this a UIP pattern or is this not UIP? So non-UIP. That's the next thing in our heads that we need to do. There has been a change in all the classifications. In August last year, we had a bunch of papers all headed by this dynamo called Chris Ryerson. And this has changed the landscape, at least of the way we use terminologies and define things. And I'll use, wherever it is relevant, the current terminology. The UIP pattern, the classic definition that was first brought about in 2011 and still remains 15 years later, is defined as the presence of reticular opacities, honeycombing, traction bronchiectasis, subpleural basal predominance, and more importantly, nothing else. No ground glass, no nodules, no septal thickening, nothing else. And I'll speak about ground glass in the next after 10 or 12 minutes. If you have the same pattern, reticular opacities, traction bronchiectasis, subpleural basal predominance, nothing else, but without honeycombing, then you call it the probable UIP pattern. And in one sense, it's just UIP without honeycombing. So the UIP pattern is this: subpleural basal predominance, reticular opacities, traction bronchiectasis, and you may or may not have honeycombing. And then you can accordingly differentiate it into probable or typical. And if you don't want to do that, just use the term UIP pattern. Now, because honeycombing defines the typical UIP pattern, it's a good idea to understand honeycombing. And we need to differentiate honeycombing from other causes of lung cysts. So here is honeycombing on the left. This image will not change. Cysts with shared walls along the subpleural interstitium extending up to the hilum, usually more than one layer. On the right, we have these cystic structures that are going from the hilum to the periphery. The simplest diagnosis that we can make on CT is that of bronchiectasis. Then we have centrilobular emphysema, where we see cysts without walls next to vessels. Again, very easy to differentiate from honeycombing. Paraseptal emphysema is a single layer of cysts typically in smokers. And they can have differing sizes, but otherwise that's what it looks like. And here you also have centrilobular emphysema. Then we have cystic lung disease, where we have cysts with walls that are randomly distributed, reparative cysts. So this patient had severe COVID-19 and eventually developed cystic disease within those areas. And this entity that occurs in smokers called airspace expansion with fibrosis, or AEF, which is nothing but traction emphysema. So some areas of emphysema are pulled apart because of fibrosis, and we get these larger cystic areas with incomplete septate. So it's called the stalactite stalagmite sign. Let's talk a little bit about reticular opacities. Like I mentioned, these are more difficult to identify and put on paper as against, let's say, traction bronchiectasis or honeycombing. And these are linear opacities, net-like. When they don't have traction bronchiectasis or honeycombing, you don't even know whether they are fibrosing or non-fibrosing. But the moment you have traction bronchiectasis with these reticular opacities or honeycombing with these reticular opacities, then we know this is a fibrosing ILD. Is there a timer somewhere? Yeah. So let's just revise this. 73 years old, has reticular opacities, honeycombing, subpleural basal predominance, nothing else. What is this? Anybody? With a typical UIP pattern. And then here we have reticular opacities, traction bronchiectasis, no honeycombing, subpleural basal predominance, nothing else. This would be the probable UIP pattern. So that's what we've done. We've said UIP, non-UIP. In this case, we've diagnosed the UIP pattern. The next step is it primary or secondary? What does this mean? If you have UIP with an etiology, then it's a secondary UIP. And there are specific causes. So this is a 27-year-old who has a UIP pattern, honeycombing, reticular opacities, traction bronchiectasis, subpleural basal predominance, nothing else. Anyone? What is this? Can you see any other sign? So we have esophageal dilatation in a 27-year-old girl. What would this be? Scleroderma. So this is scleroderma ILD with a UIP pattern. 66-year-old has a probable UIP pattern, traction bronchiectasis, reticular opacities, no honeycombing, subpleural basal predominance. But there's one other sign here which gives you a diagnosis. Anybody? The first time I'm showing you soft tissue windows. Calcified pleural plaques, which would mean asbestos exposure. This patient worked in a brake lining factory for 35 years. So this is asbestosis. It's asbestos ILD with a UIP pattern. This patient again has a probable UIP pattern, has this very typical facies. We're not clinical here. I don't think anyone knows how to diagnose by just looking at the skin and the face, so I won't ask. This is the Hermansky-Pudlak syndrome. So this is genetic ILD or a secondary ILD. So often we don't have all this history when we are reporting. So we will call it the UIP pattern and then say that this may be IPF if there's no other underlying etiology, and then kind of leave it at that. But if we know for sure, or the patient is 70, 80 years old and doesn't have any known etiology, then it becomes idiopathic pulmonary fibrosis or IPF. Then we have the non-UIP patterns. What do they look like? So this is honeycombing, traction bronchiectasis, reticular opacities on the right side. It's asymmetric. But as you look at these images, you see that there's an axial distribution in the mid-zone going from the hilum to the periphery. There's ground glass. There are lucent areas likely due to air trapping. There's upper lobe fibrosis, which is in the center. This is not like what we were seeing over the last 7 to 8 minutes. Very different. It's still a fibrosing ILD, but it's non-UIP. And the commonest non-UIP that we would see that looks like this is what we now call the bronchiolocentric interstitial pneumonia, or the BIP pattern. And I'll come to that in a minute. But these are the 5 non-UIP fibrosing ILDs, along with chronic sarcoid pneumoconiosis. So that's the definition of the BIP pattern. I feel very strongly about some of these things. I'm 61, I'm allowed to say what I want. My frontal lobe is anyway going a little, so anyway. So here we have another BIP pattern. So reticular opacities, axial distribution, little bit of ground glass, the 3 density sign here. All of this is your classic BIP pattern, which is suggestive of hypersensitivity pneumonitis if there is no underlying etiology. Here's another patient, ground glass from the hilum to the periphery, reticular opacities, traction bronchiectasis in some segments, and these areas of lucency, increasing whiteness and a normal lung, etc. NSIP, therefore, by definition, is a non-UIP pattern. NSIP, you have reticular opacity, some traction bronchiectasis, but importantly, you see this subpleural sparing, this little line of black here, which tells us that this is an NSIP pattern. Also, all the lesions are homogeneous. They look exactly the same. And almost always, when we call it an NSIP pattern, there will be underlying connective tissue disease. This entity is the reverse of a UIP pattern, upper lobe apical fibrosis with reduced volumes with a little bit of traction bronchiectasis. Anybody, what is this? It's upper lobe predominant. It's called pleuroparenchymal fibroelastosis. And then we have other patterns. So here is a patient who looks like having progressive massive fibrosis with large perihilar areas with eggshell calcification. We would think of silicosis, but the patient had no silica exposure. This was biopsy proven. Anybody? What else can look like this? Sarcoid, right? This becomes stage 4 sarcoid, and the patient actually improved on treatment. And this is silicosis, where we have nodules of varying sizes with progressive massive fibrosis, with eggshell calcification, conditions that also occur as fibrosing ILDs. So that's the flow chart. Very quickly, we identify an ILD when we see all these signs, and I'll talk about that again in another 3 minutes. Then reticular opacities, traction bronchiectasis, honeycombing define a fibrosing ILD. The moment we say this is fibrosing, we then ask ourselves, is it UIP or non-UIP? If it's UIP, ask yourself, is there a cause? If there is one, it's secondary. If there's no cause, it's IPF. If it's non-UIP, the commonest 2 non-UIPs are BIP and NSIP. BIP is the old HP pattern, but it's pretty much the same pattern. It's just the name that has changed. And NSIP typically occurs with connective tissue disease, and we should know how to pick up chronic sarcoid and pneumoconiosis as well. All of these images, all of this happens only when we have high quality images. It's not rocket science, but this is the protocol that we have. Most important is to train the patient, either the tech or the nurse or somebody who will tell the patient, take a deep breath and hold it, or in Hindi, lamba saans lo, pakad ke rakho. That is important, and that doesn't happen in India in about 70 to 80% of hospitals and scan centers across board. Thank you so much for listening to me.